I'll start with my case, ma'am. Samiksha Dhavle, a 24-year-old female, G3A2, resident of Amravati, housewife by occupation, was admitted with chief complaints of pain in lower back since one day, with white PV sticky discharge since 2 days. She had no complaints of PV bleeding, PV leaking, and she was pursuing fetal movements well. The date of her admission was 10 December 2023. History of presenting pregnancy. Her pregnancy was uneventful till now. She took 2 doses of injection tetanus toxoid. She is taking iron and calcium tablets regularly. Obstetric history. She's married since 2 years. G3A2. She had spontaneous abortion of 8 weeks in October 22nd. Her spontaneous abortion of 12 weeks in March 23. She underwent evacuation at government hospital for the same. This is her third pregnancy.
Vaishnavi,
Yes,
what
ma'am.
do you expect in history of what specific history you want in history of present pregnancy?
Sorry, ma'am, you're not audible.
What specific history you want in history of present pregnancy? You said it was uneventful. So what specific history we want in history of present pregnancy?
What specific history you want me to present, ma'am?
In present pregnancy, what specific
In history of present pregnancy, what specific history you ask?
The specific history I will ask this patient.
In this present pregnancy.
Yes.
Yes, ma'am. I'll ask this patient for the pain if she had any like complaints of pain, if she had any discharge, or specifically in this patient, I will ask for history of any preterm labor or in any spontaneous or threatened abortion in the previous pregnancy, ma'am.
Yes. So in previous pregnancy and this pregnancy also, no? She's how many weeks? At present?
She is, ma'am, 30 weeks, 32 weeks, ma'am.
30 weeks.
32.
So history
32.
of threatened abortion in this pregnancy, is it important?
Ma'am, past history of threatened abortion is important because the main risk factor for preterm labor is previous history of threatened abortion or previous history of preterm birth. So that is why this history is relevant in this case, ma'am.
So you have not specifically asked this history of threatened abortion in this pregnancy?
Yes, I have asked, ma'am.
Okay, go ahead.
Menstrual history. Her last menstrual period was 31st May 2023. Her expected delivery date was 6th of March 24. Her gestational age at time of admission was 32 weeks. Past menstrual history, her cycles were regular. She used to menstruate for 4 to 5 days, 28 days cycle. Her flow was average. She had no complaints of clots passing and any dysmenorrhea.
So Vaishnavi, whenever you are taking menstrual history, so the first part should be the history of previous menstrual cycle, then should be LMT and then EDD. Okay. So that should be the sequence of menstrual history.
Okay, ma'am.
Vaishnavi?
Yes, ma'am.
We are doing a postgraduate case presentation, right? So you
Yes,
are a consultant yourself. Now,
yes,
since she has 2 losses in the past, her this pregnancy, when she was registered and what all medications she was on, is it relevant?
Yes, ma'am.
So would you like to elaborate on that?
Ma'am, yes, I have mentioned it further in the medical history, ma'am.
No, that this is obstetric history. So her history of, as madam said, history of current pregnancy. You have to mention those things here also. Okay.
Okay, ma'am. Okay. Patient is vegetarian and her bowel and bladder habits are normal. She had no significant family history. Medical history and surgical history. She has no history of hypertension, diabetes, TB, asthma, thyroid in the present pregnancy or in the past. She had no known medical condition. Patient is not on any medication at present. She has no past history of any surgery, no past history of blood transfusion, and no drug allergy. Examination. Yes,
So
ma'am.
now would you like to
Vaishnavi,
go on
Vaishnavi.
with,
Yes,
yeah,
ma'am. Yeah.
now would you like to go on with how this pregnancy, because you said in the medical history, no drugs. Now,
Yes,
no
ma'am.
drugs, how was she treated in this pregnancy, or nothing at all was done, two losses?
Ma'am, I have mentioned earlier in the history of presenting pregnancy that she is taking iron and calcium tablets regularly.
Acha, only
So,
that much. Iron, calcium, and tetanus.
yes,
Okay.
only that
Okay.
much. Yes, ma'am.
Okay. Okay.
She
And what other
until
things
now
are
her
missing,
pregnancy was.
Vaishnavi? What other things are missing in your history, in personal history? What should be taken?
Personal history, ma'am. I should ask her about her socio-economic status. If any
Yes.
habits in India, it is uncommon, but cigarette smoking and all can impact also on preterm labor. Has its own impact on the preterm labor. Socio-economic status has its own role. So this all history is relevant in personal history, ma'am.
What is her occupation? Is it important occupation of the patient?
Yes, ma'am. Yes, ma'am. Because if if mother is, if the patient is high stress worker, if she is into some labor kind of work, or in such cases, there is more chances of having a preterm birth, ma'am. I have actually mentioned while giving the introduction of the case. She's housewife by occupation.
So she may be housewife, but she may be working in the farms and all. Okay, so that may be that is important. So history should be complete. Even if you are knowing the things, that should be mentioned in history, because each and
Okay.
every point has an importance in your case, preterm labor case. Okay.
Yes,
Vaishnavi,
ma'am.
this
Yes, ma'am.
patient belongs to, you said, na, socioeconomic history is important. So, what's Kuppuswamy, modified Kuppuswamy classification does she belong to? Because at home also, urban housewife also does how much work, what is her exertion, and all that we have to focus on, no?
Yes, ma'am. Yes, ma'am.
Acha, so,
Yes. Shall I move further, ma'am?
okay, move further.
Yes. Examination. Her pulse BP, respiratory rate were in the normal range, ma'am. There was no signs of pallor, no edema, no icterus, cyanosis, and lymphadenopathy. Systemic examination.
One
Uh,
minute,
res-
1 minute, 1 minute. Her weight is 55 kgs and height is 155 centimeters. Could you tell me how much weight gain? Because this is a very average weight. How much weight gain had she had during pregnancy?
Average weight gain, ma'am.
No,
Average
no,
weight
her
gain.
weight gain during pregnancy.
Yes, ma'am. Yes. Her weight before pregnancy was, ma'am, 49 kg, and she
Acha.
had 6 kg
Okay.
total.
Okay.
No icterus, cyanosis, and lymphadenopathy. Systemic examination. Her cardiovascular system, respiratory system, and nervous system. So, no abnormality were detected in the above system. Per abdomen, her uterus was corresponding to 30 week size. She had mild contractions present at the time of admission. It was cephalic in presentation, and FHS were regular. We did PS. There was evidence of discharge.
1 minute, 1 minute. Is fundal height in centimeters and this relevant?
Yes, ma'am.
Normally, we don't
Sorry.
take. Normally, nowadays, people have forgotten that fundal height in centimeters is to be taken. Is it
Yes, ma'am.
relevant? And why is it relevant?
Ma'am, fundal height is relevant in a few cases. So yes, we have to do maintain gravidogram in patients, because, ma'am, it gives us proper. If we can maintain a gravidogram on weekly basis, so it will give us an idea if the growth of the fetus is corresponding to the weeks. So if the growth is proper, is it happening or not? If the baby is going to land up into clinical IUGR, and so we can get the diagnosis for the same, ma'am.
Acha, IUGR is one thing, and especially with respect to preterm labor, what
Mhm.
is more relevant? Higher fundal height. Why is it relevant?
In preterm labor, ma'am.
Yes.
Ma'am, the fundal height usually increases in, ma'am, if there is any kind of cl- a retroplacental.
What?
Yes, ma'am. Just thinking. Just give me a minute.
Yes, yes.
In Yes, ma'am. In polyp.
Polyp.
No, sorry, ma'am. With the help of the fundal height, I can get to know whether the patient has polyhydroaminosis.
Yes,
If AFI is increased clinically, I can diagnose it.
yes.
Other than that, ma'am,
Okay.
large for gestational age baby, large for gestational
Okay.
age
Okay.
baby.
Is polyhydramnios likely to have a preterm labor?
Yes, ma'am. Because yes, ma'am. The one of the cause for preterm labor is multiple gestation and polyhydroamnios. Because, ma'am, it exerts a pressure on the cervix. But the uterus is overextended in the sides. That is why.
Okay. She underwent two curetages. Did she undergo rapid dilatation or misoprostol or something? Because that does it matter whether she underwent dilatation with a set of dilators in and then will it affect the cervix in any which way? She had two curetages.
Ma'am, are you talking about, ma'am? Am I audible?
This girl, yes, yes, you
Yes,
are
yes.
audible. This girl had two curetages, isn't it?
Yes, ma'am. Yes.
Okay.
Yes, ma'am. Because in cervical insufficiency is one of the cause for preterm labor. So, in cervical insufficiency, if patient is undergoing any kind of procedure like evacuation, curettage, or LLETZ, a large loop excision of transition transformation zone,
Okay. Okay.
if
Okay. Hmm.
so it can cause patient to go into preterm labor and delivery. Hence, so that is relevant in the cases of preterm
Okay.
labor, ma'am.
Okay.
Okay, ma'am.
Yeah.
We did a PS, ma'am, per speculum examination, ma'am. It has evidence of discharge, which was not foul smelling in nature. We did per vaginal examination. Her os was patulous. It was admitting one finger. It was 25%. If cervix was 25% efface, ma'am, and vertex was higher. Yes, course in the hospital. Ma'am, patient received injection Maxef IV 4 gram bolus, then 1 gram
So
per hour.
before that, Vaishnavi, what is your diagnosis?
Ma'am, this is preterm. Ma'am, this patient got delivered in the hospital. So her diagnosis is G3A2, 32 weeks, threatened preterm. Yes, ma'am. Threatened preterm labor.
Preterm.
Threatened preterm labor. Yes.
Okay, so is this a complete diagnosis?
Yes, ma'am.
In
Want me to mention anything more?
diagnosis, do we talk about presentation, etc., etc.?
Yes, ma'am. I would like to talk about presentation. She's G3A2, 32 weeks, threatened cephalic. The fetus is cephalic in presentation. Threatened preterm labor.
Single live, uterine,
Single.
intrauterine, etc., etc. SLIUG बोलते हो ना आप लोग?
Yes, ma'am. So, I think it's
So your
okay.
diagnosis.
See, it's a
Yes,
matter of
Vaishnavi.
making a habit. Huh? It's
Yes,
okay.
ma'am.
It's important because in the exam you will, if you have a habit, you will speak those things.
Yes, ma'am.
Okay.
Ma'am, single, can I go with the diagnosis, ma'am? Yes, yes,
Yes,
yes. It's a single
yes.
live intrauterine pregnancy. Okay. So G3A2, 24-year-old female, G3A2, 32 weeks, threatened preterm labor. Yes, single live intrauterine pregnancy in cephalic presentation.
Go ahead. Go ahead.
Okay.
Okay. Yeah. Course in the hospital, ma'am. Patient received injection Maxef, IV 4 gram bolus, then 1 gram per hour for 24 hours. After that, she received 2 doses of injection betnisol intramuscularly, 12 mg, 12 hours apart. However, patient continued to have contractions and went into active labor 24 hours after admission. Neonatologist was informed on prior basis. NICU bed availability was checked. Radiant warmer, resuscitation tray, suction tube, O2 support was kept ready. Episiotomy was given. Preterm FCH was delivered by Vertex presentation on 12th of January 24 of 1.4 kg. Baby cried immediately after birth. She was handed over to the neonatologist. There was no evidence of postpartum hemorrhage. Post delivery period was uneventful. Baby is in NICU at present. Baby did not require any ventilatory support and surfactant. Oral feeds were started for baby from day 5 of her birth. Mother is discharged from our side and she is now shifted to NICU.
Okay. Could you tell me patient delivered in after 24 hours of admission, right?
Yes, ma'am.
Acha. So obviously that magnesium sulfate you had given.
Hmm.
How long did your magnesium sulfate last?
Ma'am, yes. In this case, once the patient cervix was dilated, which did stop
So when was cervix dilated?
in active phase of labor. Once
I
the
know
patient
when. When did it dilate? When did she go into active labor? She was admitted at one finger dilatation.
Acha. From what time of admission she? Acha. Okay, okay,
So
ma'am.
you
You are
were
asking.
monitoring you or whoever was monitoring the patient. Yes. So in monitoring, at some stage, somebody realized that magnesium sulfate was ineffective. Yeah.
Yes, ma'am.
How long? So 1 gram per hour for 24 hours. And magnesium sulfate was not effective. So it must have been because when we keep a hand on the abdomen, somebody must have realized at some stage magnesium sulfate was not working. Yes.
Well,
What are
ma'am, magnesium sulfate. In this case, we also gave for neuroprotection.
that I understood. Yes, yes, yes. But it
Yes.
was neuroprotection for if we give for neuroprotection. Could you tell me for how long do you give for neuroprotection?
Ma'am, yes. For neuroprotection, we give for 24 hours, ma'am.
Acha. So here you mean to say that it was given for neuroprotection and there was no need felt of any other tocolytic to arrest labor.
But ma'am, both.
Okay, doesn't matter. Now
Yes, ma'am.
what I want to know is
Maxim basically in this case had with the thought process of getting both dual effect. One is for tocolysis and other for
yes,
neuroprotection. Keeping that in mind, Maxim was initiated, ma'am.
absolutely. So now tell me
Hmm.
this if we are giving retinool to increase the lung maturity,
Yes,
when
ma'am.
would we like the patient to deliver after how many hours of the last dose?
Ma'am, ideally patient should be delivered after 48 hours of the last dose.
At least 24 hours, no?
At least 24 hours. Yes,
Uh,
ma'am.
So would you have in normal circumstances arrested labor for that?
Ma'am, with the perception of that magnesium sulfate will help with prolonging the process we gave,
Acha,
but in this case, patient did went into active labor after 24 hours in spite of
acha,
giving magnesium sulfate. Yeah.
acha, acha. Okay, okay, ठीक है.
So, Vaishnavi, what are the risk factor in your patient for preterm labor?
Ma'am, the main and most important risk factor for the preterm labor is a prior history of preterm labor. Other than
In
that,
your patient, what are the risk factor in your patient?
in my patient, ma'am, this patient had a previous cervical evacuation procedure, so this was the risk factor for in this case. Other than that, ma'am, she had history of 2 abortions which was first trimester. Ideally second trimester abortions are important and relevant for preterm labor. She had one 8-week abortion and second 12-week abortion. So in this case I will consider even that as a risk factor. Other than that, ma'am,
Do you think,
yes,
Vaishnavi,
two
you
of this,
have um,
two of these factors.
omitted to tell certain risk factors or absence of risk factors, as madam is asking?
Other
You
risk
said,
factors.
you said there was cervical discharge, yes?
Yes, ma'am.
Had you taken a
Yes, ma'am.
cervical swab?
Yes, ma'am. Yes, ma'am. We
What had
did.
it grown? And what is the
Uh,
relevance if suppose patient
yes,
delivers
yes.
and you require to, you have taken swab, abhi deliver ho gayi, abhi swab ka kya fayda? What is
Yes.
the utility of that swab?
Yes, ma'am. We did take the swab, high vaginal swab. It has infective etiology, and then, ma'am, it is important because we can give the antibiotic prophylaxis based on the organism found. As in cases of preterm labor, bacterial vaginosis is a very common infection. So it is important to for the patient in future aspect also post delivery to give her the antibiotic cover, ma'am.
Acha. Now tell me, uh, that swab report, culture report will come after minimum 48 hours, right?
Yes, ma'am. Provisional report. Yes.
Provisional report will come after 24 hours. Definitive report may come anywhere between 24, 48 to
48 hours.
72 hours. What is the utility of that report?
What is the
Utility of that report?
change in
So mother
change
has
in
already.
prophylactic antibiotics, ma'am. If we have
So,
started on any antibiotic and then the patient is showing resistance to the same, and it is not it is not sensitive to that antibiotic, so we can start with antibiotics which she is sensitive for. It can show a better outcome in case of patient. Patient won't land into raised WBC counts or complications.
Now patient has delivered. Your patient has delivered, no?
yes,
Yes,
So
ma'am.
what is the significance of that report?
Yes, ma'am. Even for neonates, ma'am, the neonate will be with pediatrician, but we can inform the pediatrician, and then we can tell them about the report, and even they can start line of management based on that report, ma'am.
because whichever organism the maternal genital tract has colonized, which is the commonest organism that maternal genital tract is more worrisome colonizing, and that is at the neonate is at risk.
Ma'am, beta streptococcus, GBS, ma'am.
Okay. Do you believe that in a case of a threatened preterm labor,
Mm-hmm.
one would empirically treat patient for vaginal infection with antibiotic?
Yes, ma'am.
Any
There are various
advantage
studies.
treating
Various
the
studies.
patient prophylactically and empirically without a culture report? Because
Hmm.
culture report is going to take time. Do we empirically treat patient for vaginal infection?
Yes, ma'am. Patient is yes. There various studies were done on the based on for this proposition. So it was concluded in various studies that if we start erythromycin as an empirical therapy treatment for any patient who has swab is positive, and it can be beneficial for the patient, ma'am.
Achha.
In
Okay.
in which preterm patient you will give antibiotic?
Ma'am,
For
preterm patient who is having PROM, PPROM.
yes.
Yes.
Hmm.
Intact membranes we can think of giving, not compulsorily, but in cases of PPROM, we have to, ma'am.
So only PPROM, and if your culture is GBS positive. Only
Yes, ma'am.
these two are the indications for starting the antibiotic in preterm labor. Otherwise, there are no recommendation to start the antibiotic in patient with preterm labor. Okay, prophylactic antibiotic.
Yes, ma'am.
So will you do screening for bacterial vaginosis in every patient?
Uh, Bacteria, yes, ma'am.
For
Uh,
every
eh,
patient, you will do screening for
for
bacterial
patients
vaginosis.
of preterm labor, ma'am, yes.
So high risk patient. No?
Yes, high risk patients, yes.
So in high risk patient, you will do screening. And in low risk patient,
No, ma'am. Low risk patients, we can start
so
therapy.
as such, So as such, the screening for bacterial vaginosis is not recommended in low risk patient, but
Hmm.
there are no definitive guidelines for high risk patients.
Yes, ma'am.
Could you tell me which other investigations would point to some risk factor for preterm labor in this patient?
Yes, ma'am. Recently, in about countries abroad, fetal fibronectin has gained a lot of
No, 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 no,
importance.
no, no, no. I'm not talking of fibronectin. Forget
Sorry, ma'am.
fibronectin. I'm talking of whatever is the routine antenatal profile. Are there
Yes.
any tests which make or which help us categorize patients into, as Madam said, low risk, high risk, etc., etc.?
Ma'am, we can categorize patient on the
Because I
WBC
have not, I must have
CRP report.
for I must not have registered you telling me, but the antenatal investigations uh,
Hmm.
uh,
Yes. I think, ma'am, there is relevance of in antenatal profile. There is relevance of CRP and WBC counts in mother
in a
who goes
routine
in.
antenatal profile, my dear, CRP and WBC count is where the patient is has come with a problem.
Hmm. Sorry, ma'am, I didn't get your question.
would a patient, though now her that past history is there, what are the
Okay.
recommendations, current recommendations about elimination of syphilis
Yes,
in
sir. Yes, ma'am. Yes. I can go for a cervical length scan, which is now routinely practiced in between 16 to 24 weeks of gestation, ma'am.
Okay.
So TVS in TVS, while doing TVS, three factors will give me a clear idea whether there is a dilatation of cervix, whether there is funneling of cervix, and the effacement. The three factors I'll get to know by TVS, and then accordingly I can, if the if patient is dilated and effacement is good, so I can come to know whether the patient is a high risk for preterm labor or not. And
Dilated
depending on that, I can.
she is iris she is going to go into labor. Which are
Yes.
the patients? No, if, at what, in which patients will you do? You have normally done it in this patient.
Ma'am, in patients who is having prior history of again preterm labor, in patients who is having threatened miscarriage in the second trimester, had miscarriage in the second trimester, in such cases we should go for TVS, ma'am. Lens, cervical lens scan, ma'am.
अच्छा, okay. Okay. With two abortions also you wouldn't do this in this patient.
Yes, yes, ma'am. Ma'am, this patient had two abortions, but
Ever first
indication.
trimester. She had rapid cervical dilatation. I do not know what actually
Yes, but
happened at that
yes.
time. But anyway, okay. What about her VDRL report? What about her HIV report?
Ma'am, yes, I didn't mention the investigation slides, ma'am. Her investigations were normal. Her HIV, HbA1c and VDRL profile were negative, ma'am.
What about urine investigation?
Urine report was also normal, ma'am. Pus cells, epithelial cells were all into normal range.
When were they?
So
When was it done?
On date of admission, ma'am.
Okay.
So what we are particularly interested in only that urine routine microscope or something else?
Urine, particularly interested in urine routine microscopy. Ma'am,
Routine
because yes, with the help of pus cell counts, I can get to know whether
so
patient
you
is
are
having.
doing culture sensitivity, no?
Yes,
Urine
ma'am.
culture sensitivity. Huh?
Yes, ma'am. So if the pain she is having is due to UTI or it's a preterm labor, so I can distinguish accordingly also with the help of urine routine microscopy and culture sensitivity, ma'am.
On history, how do you differentiate between pain of UTI and pain of preterm labor?
Yes, ma'am. Pain of preterm labor, ma'am, will be increasing in intensity, gradually increasing in intensity. It will be associated with cervical ripening and effacement, and gradually progressive in nature, ma'am.
On history.
History, ma'am, hardening, ma'am. Ma'am, I will feel contractions.
History.
History.
Um,
UTI mein what
in
other
between,
symptoms are there?
ma'am, this contractions will be associated with relaxation, and they will be regular in nature. And in case of UTI, ma'am, the patient will be having pain which is radiating, which is colicky in nature, and it is radiating from groin to groin, ma'am. And
In all UTIs, pain radiates from loin to groin.
no, not all, ma'am.
Which are the common UTIs? Pyelonephritis or ureteric pain we are not talking about. There could
Yes.
be ordinary cystitis, no?
Yes, burning micturition. Ma'am, patient will
Uh,
be complaining of burning micturition,
what else does she complain? What
increased
burning?
frequency of micturition, ma'am.
Acha. Tell
Pain
me,
on the
tell
lower side.
me now, frequency of micturition. How will you say this frequency of micturition is a problem? Because as the baby's head comes down, all women
Hmm.
have frequency of micturition.
Hmm.
So,
So by ma'am, doing the routine investigations of URM, I'll get an idea whether it is due to UTI or it is labor induced pain, ma'am.
acha, madam said culture. Tell me how to advise a patient to collect urine for culture.
Ma'am, I will advise patient to collect midstream urine because, ma'am, as it can give a false positive report if initial urine is collected and even later. So midstream is a specific induction indication which I will give to my patient.
So what is midstream clean catch? What is clean catch?
What is?
Clean catch. Midstream.
Sterile bottle, ma'am.
Sterile bottle
Clean
is
hands.
one thing, but
Sterile bottle. Clean
can
hands.
cervical discharge mix with her urine?
Cervical discharge and urine, ma'am. Difference.
No, no. Okay, okay, doesn't matter. Go ahead, go ahead. So now this baby has baby was delivered at 1.4 kilos and
Yes,
baby
ma'am.
died immediately after birth, and baby did not require surfactant and all that. Could you tell me problems in a baby with 32 weeks, 33 weeks maturity?
Problems faced by preterm newborns, ma'am. Okay, ma'am. Usually in this age group, respiratory distress syndrome, interventricular hemorrhages, necrotizing enterocolitis, bronchopulmonary dysplasia, retinopathy of prematurity are common things which we see generally in preterm newborns, ma'am.
Okay, these are I didn't say complications. These are really complications, and these are severe ones. Ordinary ones are which ones?
Respiratory distress is
Ordinary
common.
ones. Ordinary ones that happen to these patients, and that's why we have to guide the mother to do some things. So, lot of things have to be told to the mother. Mother
Mm-hmm.
discharge with the baby home, but with a lot of advice. So, what is that advice?
Ma'am, basically, in such patients, I'll advise mother to give a proper breastfeeding. Other than that, hypothermia is very common
What
in
is
preterm
proper
birth.
breastfeeding?
Proper methods of breastfeeding, like completely covering the nipple in the sitting position, held head properly around the areolar region, ma'am.
Why does she have to sit only and give feed?
Sorry, ma'am. Why does?
Should she always sit and feed the mother baby?
Yes. Yes, ma'am.
Acha. Okay.
Hmm.
Can't feed. She can't
And
feed.
then, ma'am, even hypothermia is very common in preterm birth, preterm
Yes.
neonates. So
Yes.
I will advise mother to keep the baby warm as much as possible. And even during delivery, as soon as baby, I will try to deliver baby in the warm towel, and I immediately shift the baby in the warm towel to the
How do you
radial
make the towel warm?
autoclave. When warmer, yeah, this hot, warmer,
Warm
warmer,
towel
ma'am.
means how do you make the
Warmer,
towel warm?
warmer, ma'am.
Warmer. How much should be the temperature of the towel? Don't feel bad. I'm
Temperature, ma'am, normal body
even
temperature.
wrapping the baby in a towel is good enough. That will help, unless
Yes,
your whole ward is air conditioned, etc., etc. But then,
yes, ma'am.
what is the recommended method nowadays of keeping the babies warm? What is kangaroo mother care? Could you tell me?
Yes, ma'am. We immediately, as soon as baby is
Kangaroo
delivered,
mother care.
yes, ma'am. We hand it over to we keep it on the maternal like body, mother's body, to give heat provide the heat
No,
to the
no,
baby.
beta. Kangaroo mother care is something very specific. Kangaroo
Yes,
mother care is where
skin
the
to skin.
baby. Bolo.
Skin. Yes, ma'am. Skin to skin contact is
Acha,
initiated.
how is that achieved? How is skin to skin contact achieved?
Ma'am, I'll open. Yes, ma'am. I will advise mother to completely to be bare chest, and then I will place the baby over the chest, and maximum surface of the new baby's body should be touching to the maternal skin. It will provide heat to the baby and cover the baby from behind, ma'am. Cover the baby from all the sides. Only the front side, which is exposed to the maternal body, should be open, ma'am.
What is that kangaroo bag? There's a special bag available, or ordinary
Yes.
at home, so they can prepare. And who can give this
Yes, ma'am.
kangaroo
Yes,
bag?
we can. In rural areas, still, ma'am, we use only to tie the baby to the bare chest directly, not from the both the sides, and it is tied to the mother's back, ma'am.
Acha, who else can give kangaroo care?
Anyone can, ma'am. Even father can give kangaroo care, ma'am.
Yeah. So kangaroo care can be given. And what are the advantages? One is you said temperature maintenance. What else?
Yes, ma'am. Ma'am, even bonding, it helps in bonding.
Okay. So where was this practice of kangaroo care started? Do you know? If you don't know, it's all right.
I
Doesn't
don't
matter.
having idea, ma'am.
Doesn't matter. Doesn't matter. So you said proper breastfeeding. One, you said latching, and you said the position. What
Yes.
else? What else?
So, head, ma'am, proper head support,
That positioning, where
lower
body
lip,
is the same
lower.
vertical axis as the head, etc., etc.
Yes, ma'am, head access, and I'll see to it that the nipple, the baby's lips, lower lip is completely everted and it's completely covering the nipple, and I will give support to the head and neck, ma'am. Neck
Acha,
is straight.
acha. So now this preterm baby, how many? How do we know about baby having had adequate feed? She has gone home, na? So
Yes.
feed is adequate. How will one know?
Sorry, ma'am, can you repeat the question?
How will she know she's breastfeeding the baby? How will
Yes.
she know the baby's feed is adequate for baby?
Yes, ma'am. We will term it as adequate if baby is not crying, ma'am. The temperature of the baby is normal. Baby is not
Baby
having any
cries
signs
because of what all things, Vaishnavi?
cries, ma'am, when baby is hungry or having any having any pain complaint in the body. So the way of expression for the baby is crying, ma'am. Other than that, I will look for hypoglycemia. If the baby's RBS status is normal, it means it is
नहीं नहीं
adequately
अभी
fed.
she has gone home. RBS अपने को मालूम नहीं है.
Acha, okay. Hydration, hydrate
So,
well, proper
yes. So how
urination.
many times should the baby pass urine?
Ma'am, urine should be passed on the daily basis, ma'am.
Daily basis. How many times
12,
should
ma'am,
the nappy
ma'am, 12,
nappy be?
6 to 12 hours, ma'am.
6 to 12 hours. What is that?
Sorry, ma'am. 6 to 12 times, ma'am, a day.
6 to 12 times a
Yes,
day.
6 times a day, so that is 4
Acha,
hours, 4 hour life.
acha. What else? What else shows that the baby is adequately nourished? Because once it's
Ma'am,
gone home, there
even
is no way of knowing, you know.
ma'am, even if normal sclera, there is no signs of hyperbilirubinemia, will even indicate that baby is properly fed, ma'am.
Which babies have got hyperbilirubinemia, and when does that hyperbilirubinemia, which is not pathological, when does it come?
Third day, ma'am. Third day.
Where was the baby on third day?
Baby was in NICU, ma'am.
So that hyperbilirubinemia is not the factor that we are worried about now, no?
Yes, ma'am.
Okay. When does baby lose weight? And when does baby regain the weight?
Ma'am, first initial 10 days, initial 7 to 10 days, ma'am, baby is losing the weight. Later on, it starts gaining weight.
When does baby start losing weight? When does it start regaining weight? And how much weight is permissible to be lost?
10% in first 10 days, ma'am, is permissible loss.
First 10 days. Okay, that's a long time. When was this baby discharged?
Ma'am, baby is not discharged. This baby is not discharged yet. It's in NICU. Oral feeds has been started
Acha,
for the baby.
you discharged the mother.
Yes,
Okay,
ma'am.
I
Mother was
understand.
discharged and shifted to NICU, ma'am.
Shifted to
Baby
NICU. Why is
started
the
on
mother? Okay. I got it. Sorry.
6 to 8 ml feeds now, ma'am.
Acha, 6
Per
to 8.
hour.
Okay. So I got confused. I'm very sorry. Okay.
So, Vaishnavi, how will you manage the labor in preterm patient?
Ma'am, management basically in preterm, ma'am, we first will initiate with tocolysis, tocolytic
And
agent.
patient is in labor now.
Active
Okay.
labor.
Active labor.
Act-
So, how will
active
you
labor.
manage labor? First stage, second stage?
Uh, Hmm. Ma'am, in first stage of labor, I will initially I will just I in preterm delivery, ma'am, I have to shorten the duration. I cannot allow this labor to be prolonged as it can cause effects on the baby as baby's organs are not completely developed. Fetal lung maturity is not completely achieved. So I will try that the labor is not prolonged. For that in that case, so I will start. I'll give her antibiotics. I'll give her analgesics. I will try to augment the labor with the help of oxytocin. Other than that,
For
ma'am,
every
Wait,
patient, you will.
Vaishnavi,
if no, ma'am, if
when
patient is
she's
not
al-
adequately dilated, yes, ma'am.
when she's already in labor, why do you want to augment her labor?
If ma'am, if I'm saying if it is prolonged, in the cases where it is prolonged and patient is not adequate, dilation is
Abhi, if
not adequate.
somebody has gone into preterm labor, tell me
Hmm.
which labors will get prolonged.
Ma'am, prolonged which labors will get? In cases of head which is deflexed, ma'am, malpresentation.
Preterm है ना, छोटा सा है ना.
Oh, so 1.4 kg है.
हाँ. So deflexed head, normally why does deflexed head cause prolonged labor? Tell me.
Ma'am, deflex head can cause prolonged labor because, ma'am, descent will not be
Why?
adequate.
Why?
BPD and biparietal diameter will not be
This is
fixed.
a small baby, so biparietal diameter also will be small. By the way, in deflexed head, is it biparietal diameter that matters or some other diameter that matters?
Oh, occiput of frontal, ma'am.
Acha. So this is a small baby. So in small baby, what is if somebody were to start augmenting, I would be very worried. Why would I be worried?
Hmm. Bending. Hmm. Sorry, ma'am.
Okay, doesn't matter. So I would be worried because first, she's already in labor.
Hmm.
Secondly, without electronic fetal heart monitoring, if I'm monitoring this labor clinically, then
Hmm.
suppose somebody goes into hypercontractility or hyperstimulation, preterm baby will have more serious outcome as compared to a term outcome.
Yes, ma'am.
That is one thing. Already preterm labor and then I'm augmenting means there is a big chance that there would be, if not precipitate, but a very rapid labor.
Yes,
Okay,
ma'am.
that is one thing. Now, rapid labor, what problems does it cause to the intraventricular vessels?
It can cause intraventricular hemorrhage, ma'am.
Why?
Ma'am, because lateral intraventricular lateral ventricles it has the blood vessels
No, no,
passing through the
that I understood.
and
But why will it cause hemorrhage in this baby?
because there will be contraction of the
That
fetus
always
head.
occurs. That always occurs. That occurs in every baby.
Hmm.
Huh. If the contractions are rapid or if she is going through a very strong contractions, the rapid
Repeated pounding of the head, ma'am.
and
Repeated
sudden
pounding.
decompression will cause the problem.
Suddenly,
That is
yes,
why
ma'am.
what is the recommendation? People actually recommend
Episiotomy.
applying forceps as a protective this also for preterm labors, isn't it?
Yes, ma'am. And even, ma'am, in preterm cases, there will be fragile blood venous
Okay.
system
Okay.
that can
Okay. Okay.
be a aid to it. And even that is why, ma'am, in such cases, due to like sudden decompression, to avoid sudden decompression, we give episiotomy. In this case, also we took episiotomy for the same reasons.
Yeah, yeah. Okay.
So
What you
after
mentioned analgesia. What analgesia will you go?
Ma'am, normally in our college, we follow injection tramadol as an analgesic, ma'am.
So what type of analgesic is that?
And it's opioid analgesic, ma'am.
Okay. At what stage should you be giving the last injection, if at all? How many injections would a patient require?
How many injections?
What is the frequency of giving injection tramadol?
12 hourly? 6, 4, remember, ma'am, so 6 hourly.
Okay.
6
If I
hourly.
gave it
4 doses we can repeat.
if I gave it near delivery, full dilatation and all that, would
Hmm.
there be some effect of tramadol on the baby?
Yes, ma'am. Maybe, ma'am.
When will you clamp the cord after delivery of the baby?
No, ma'am. Delayed cord clamping will be practiced in this case, ma'am.
So delayed means after how many time?
Till the pulsation is pulsation stops, ma'am. Pulsation is
So
present.
in which patient you will not do delayed cord clamping? In which
Uh, in patients which are seropositive, and even in patient in which there is sort of a respiratory distress in the fetus. In that cases, we will
In
immediately.
the fetus, how does fetus get respiratory distress?
Sorry, ma'am. For ma'am, I wanted to
I
actually
understood.
mention
So
Fetal distress.
the
newborn,
babies
newborn.
which require the urgent
Initial step.
resuscitation, in that babies you will not do delayed cord clamping. Okay.
Yes, ma'am.
And in which mothers do you not do delayed cord clamping?
Sorry, ma'am.
Which maternal problems do you not do delayed cord clamping?
Seropositive, ma'am.
No, that is one thing. Seropositive, you don't do it for baby's sake, but for mother's sake, in which mothers do you not do delayed cord clamping?
In mother fetus, delayed cord clamping.
Whenever mother is in a critical condition, you require to finish your procedure fast, isn't it? So the position of the mother for delivery is going to matter. So you require to be cautious about how the maternal health is. Now, actually, we don't have the birthing chairs. Yes. So how the mother is breathing, whether the mother has any cardiac problem, that numerous factors which decide whether we will, from the maternal aspect, we will do normal cord clamping or early cord clamping. No?
In which preterm patient you will go for LSCS? In which preterm mother?
In preterm cases, usually LSCS is not indicated unless and until there is for a viable fetus, which is about 24 weeks. If there is not any fetal indication like fetal distress, ma'am, in such cases we have to go for LSCS.
in
Otherwise,
which
we will give vaginal trial.
No, you hear the question properly.
In which preterm babies you will go for cesarean section?
Preterm.
Think about the presentation, everything.
Malpresentation, yes, ma'am. Malpresentation.
Malpresentation, which malpresentation?
Breach, ma'am.
Breach. So preterm breach, you will do cesarean section.
Yes, for LSCS, ma'am. And even fetal distress, ma'am. This is the indication for LSCS, yes, in preterm labor.
So any obstetric indication, you will go for cesarean section. Otherwise, vaginal delivery.
Yes, ma'am. Obstetric indication like antepartum hemorrhages, antepartum hemorrhages, or ma'am, preeclampsia, we can go for LSCS, ma'am.
Eclampsia, should you do? This is necessarily cesarean.
No, ma'am. We can give trial.
Achha. So you will decide based upon the merits of the case.
Yes, ma'am. Depending on the merits of the case.
It's already 8. We have to wrap up.
Okay. Well,
Shortly, which tocolysis you will use?
Tocolysis agents, ma'am. In this case, we have used a maxi for the tocolysis agent, but recently there are other advances and hydroxyban.
There is lot of disturbance from your side, Vaishnavi. Yeah.
Recent advances, there are a lot of drugs has been under the trial.
So what is the recommended first line of treatment as a tocolysis? Is the first
Maxi and nifedipine.
Myself and nifedipine.
In between,
Vaishnavi,
I'm just going to ask you one last question.
Vaishnavi, can I
Yes, sir.
ask you one question?
Yes, sir.
Yes, madam has already asked you about the tramadol. Supposing that inadvertently you are given tramadol even after full dilatation and the baby is going to be delivered, but in which case it will be beneficial for the sake of baby,
Beneficial for the sake of baby, ma'am. Baby, sir.
right? Right. Otherwise, you don't allow, isn't it? You don't advise, as madam
Well,
has said already.
yes. Sir, mm-hmm. Not able to. Maybe.
How it will be beneficial to the for the sake of baby if you give it late in delivery, the tramadol
Sir,
injection
bearing down effect of baby,
for
bearing
the
down
sake of
effect
baby.
for mother's bearing down will be good, so it will indirectly facilitate the baby's delivery. So there will be.
Do you mean to say rapid delivery is beneficial for the baby?
Sorry, sir, your voice is not clear, sir.
No, no, it is not related to the time of delivery. See, madam has already told you that the decompression and sudden decompression is going to be harmful to the baby, isn't it?
Yes,
It
yes,
has
sir.
to be slow.
Yes,
My
sir.
question is how tramadol is going to be helpful in case of baby if it is given in late, say after full dilatation of the
Yes,
cervix,
yes, sir.
because
Sir,
otherwise it is not beneficial. It is harmful.
it will help in expulsion and in second stage of labor, sir. It will help in expulsion and propulsion. Otherwise, there will be a regression, and
No,
because of
okay,
regression,
I will give you a clue. Supposing that there is a meconium stain liker,
hmm.
so will it be helpful for the baby if you give tramadol?
Hmm.
What happens with tramadol? Think about it. What do I want to do if there is meconium? What do you do as a neonatology this thing residents?
Suctioning. Suctioning.
Now tell sir why it is beneficial.
Any fluid which is collected fluid in the lungs, it can help in that manner, ma'am. So suctioning can.
No. Tramadol. You're talking about tramadol. Is it going to be helpful or it is not helpful for the sake of baby? In
Helpful,
case
sir.
how?
Baby will not aspirate meconium, sir.
Why baby will not aspirate?
Sedation.
So what happens with sedation?
Sedation, deep breathing.
Forget about deep. There is respiratory depression.
Yes.
Okay.
Sorry, sir.
So,
No.
so the baby will not have respiration, so no aspiration.
Yes.
That will help in preventing the meconium
I'm so
aspiration
sorry,
syndrome,
sir.
right?
I couldn't think in that way. I'm so sorry.
Yeah.
So
It is always
Vaishnavi,
forget about the prematurity. Any case of meconium stain liker, if you don't
Hmm.
have facility, you can sedate the patient and
Hmm.
then you suck out the meconium whatever is there in the throat, and then
Hmm.
you start oxygen or on the by mask, ventilated by mask, so that
Hmm.
there is no meconium aspiration.
Okay.
That is the way in which is how it is treated.
Yes, sir.
so Vaishnavi, last question. If you want to give progesterone for the prophylaxis, which
Yes.
progesterone you will give and for which patient you will give progesterone?
Hydroxy progesterone, ma'am. But yeah, generally, ma'am, it just depends upon the cervical length of the patient. If the cervical length is short, if cervical length is short, the mainstay of my treatment will be giving progesterone to
Short,
the
short means
what is less than 25 mm, ma'am.
yes. So you will give 17 hydroxyprogesterone. or any other progesterone?
Yes, ma'am. 17 hydroxyprogesterone.
So according to new guidelines 2023, 17-hydroxyprogesterone is not indicated or not recommended. Only progesterone which is recommended is vaginal progesterone, that is micronized progesterone. Okay. 17-hydroxyprogesterone is not recommended at all for
Yes,
the
yes.
prevention of preterm.
Micronized, yes, such thin capsule in form
How
of.
long do you give progesterone, Vaishnavi?
Ma'am, till 34 weeks, ma'am.
So we can give till 37 weeks also. Okay.
Okay,
The
ma'am.
recommendation is till 37 weeks. So you can give
Okay.
progesterone till 37 weeks.
Okay.
So I think our time is over, is it?
Yes, ma'am.
Yeah. Okay. Okay.
It was a wonderful
Thank you,
discussion.
ma'am. Thank you so much, ma'am.
Really
Thank
very
you
nice
so much, sir.
practical tips. I think we'll be together. We'll have a one group photo. I think Dr. Surti is also there. Please open up your windows. We'll have a group photo.
Yes, yes.
Good evening, Dr. Sushma. कैसे हैं आप?
Good evening, बिल्कुल कैसे हो?
ठीक,
So
thank you.
I caught you.
Pleasure to be here with you.
Yeah, we would love to listen you. So we'll have one photograph.
Please stop sharing first. Please stop sharing first.
Yeah, we have stopped, sir.
हो गया? Corona people?
Yes, ma'am.
It's over? Okay, we can go ahead.
Yeah. Thank you so much.
Thank you so much, ma'am.
Thank you, ma'am. Dr. Nanku Padmaja, ma'am. Dr. Kanchan. It was
Thanks
a
a
very
lot
good
for giving
discussion.
us the opportunity to participate in this. Thank you.
Thank you, ma'am.
Such a great discussion with lots of learning points to remember. I thank our examiner, Dr. Padmaja ma'am, Dr. Kanchan ma'am, and also I thank Dr. Vaishnavi for such an interesting session. Moving to the next session, that is Pearls of Wisdom, for which I would like to welcome our chairpersons. Dr. Ajit Deshpande sir. He is a renowned consultant gynecologist, infertility specialist, and laparoscopic surgeon. He is a director of Mohini Hospital IVF Center, Shirampur, Ahmednagar. He has been past secretary, past vice president, past president of IMA Shirampur. He has been invited as a speaker and faculty in various state and national level conferences. He has multiple publications in national and international journal under his name. I welcome you, sir. Now, I introduce our next chairperson, Dr. Sahili Jahagidar ma'am. She's an associate professor at Dr. Punjabrao Deshmukh Memorial Medical College, Amravati. She has been a clinical secretary in Amravati OBGY Society, chairman in IMA, etc. She has received the late Shailaja Chaudhary Award for Academic Excellence in 2018. She also has multiple publications under her name. I welcome Saili ma'am.
Thank you.
Now, I would like to hand over to our chairperson for further proceedings.
Welcome, Dr. Sailin, Dr. Ajit Deshpande, sir.
Thank you,
Thank
ma'am.
you.
Should I start, ma'am? Should I start? Hello.
Dr. Tina, please introduce Agrawal ma'am. Dr. Tina.
Am I
Ma'am,
audible?
Yes, you are. Yes, you are.
Yes. I would like to introduce our speaker, Dr. Smriti Agrawal, ma'am. She has done MD from PGI Chandigarh. She is professor and head of the Department of Obstetrics and Gynecology, RIMS Lucknow. She has been awarded Professor Dhavendra Kumar Young Investigator Gold Medal by KGMU Lucknow. She has received Icons of Health Award by Times of India Group by Honorable Health Minister. She is a member of core group to revise EMONC curriculum of MOHFW 2019. She has also formulated guidelines in medical disorders in obstetric and genital tuberculosis for Ministry of Health GOI 2015. She, I, she has a special interest in fetal medicine and reproductive medicine. She has more than 55 publications in reputed international and national journals. I welcome Smriti ma'am.
thank you so much. Am I audible?
Yes, ma'am, you're audible.
Thank you so much, Dr. Sushma. It's a pleasure to be connected with Nagpur Society. And thank you so much and giving me this opportunity to interact with your postgraduates. And I continue to learn from the postgraduates. And I was just listening to the case discussion also. It was wonderful. This is a very good effort from Nagpur Society. Thank you for having me. So today, in the next few minutes, we will talk about cardiotocography, which is a very, very common test used by the postgraduates of Department of Obstetrics. And I would just like to revise the basic concepts and also introduce an update on it. So these are the following things which I would cover in the next few minutes. Very briefly about the CTG machine, Dr. C. Bravado approach. What are the guidelines which are there? Because there are three of them which are very commonly used, and there is some kind of a disparity in them. The pitfalls and the complex presentations and the advanced CTG techniques. So we know that cardiotocography, it's a technical method in which we record the fetal heart rate and the uterine contractions. The machine we know is called as cardiotocograph and more commonly known as electronic fetal monitor. We know that we use this machine both antepartum in order to know the autonomic function of the fetus, and we also use it intrapartum to monitor the fetal response in labor. Basically, it uses ultrasound to detect the fetal heart rate, and it uses the principle of Doppler effect. We all know that. So we know that there is a motherboard, there is a power cord, and there is a 3-in-1 probe, which uses the ultrasonic probe, the contraction probe, and the fetal movement pen. And we know that the toco probe is attached to the fundus of the uterus with less pressure. The ultrasonic probe is attached where the fetal heart sounds are heard by auscultation. And the fetal movement pen is given to the pregnant woman where she presses each time she experiences a fetal movement. So we all know that we use the CTG machine very often. And I just wanted to also add a few things about the maintenance which is needed about these CTG machines. Remember that you don't really need to use any strong solvents. Don't use any abrasive material. Don't use any liquids to clean your CTG machine. Just wipe it with tissue paper in case it gets dirty. Then you can use some kind of a sterilium on a tissue and then just wipe it clean. Don't pour the liquid into the machine. You can, if you want to disinfect, you can just wipe the probe with the help of 70% alcohol, the sterilium which we use, and use dry and soft cloth to wipe the liquid material. The coupling agent should always be water-based jelly, which we use for ultrasounds, and not oil-based. So a lot of times we see in our labor rooms that the woman is lying completely supine and the CTG machine is attached to it. It is important that to know that it is not an ideal position because there is an autocaval compression by the pregnant uterus, which affects the placental perfusion and fetal oxygenation. So prolonged monitoring, if you have to do, don't do it in this position because it is bound to show some kind of abnormal features and where you would be over diagnosing the abnormalities of CTG. The ideal positions are lateral recumbent, It can be half sitting or upright position. They're definite preferable alternatives. There are a lot of portable sensors, also portable fetal monitors, which are available. And they can transmit the signals to a remote fetal monitor, sometimes even to our phones, the smartphones. And we can continue to monitor the lady remotely when she is in the labor room. Now, when we talk of CTG, we remember that there are two components, cardio and toco. So we're talking about the fetal heart rate and the uterine contractions. The paper runs at a speed of 1 centimeter, 2 centimeter, or 3 centimeter. Now, there is nothing to suggest which speed is better. Whatever our eyes are trained for, we should use that speed. The commonly used speeds are 1 centimeter per minute or 3 centimeter per minute. So there is completely no reason for you to choose one over the other. You can choose either of the speeds. Basically, we get used to a particular kind of a pattern, so it is important to stick to one particular paper speed always. Now we know that this is how a CTG paper looks like, where you have boxes and each box has, now when there are vertical, there are 30, there's a difference of 30 beats. So each small space of vertical corresponds to 10 beats. And depending upon the paper speed, 3 centimeter per minute means this is like 1 centimeter. So 3 boxes will mean 1 minute. So that is how, so that means each box will be 20 seconds. So this is a very basic way of understanding how the CTG is interpreted. Now, when we talk about CTG, we will talk about the components of CTG. We know that there are 4 components: the baseline, heart rate, then of course the accelerations, decelerations, and variability. Now, baseline fetal heart rate is the most important, and it is very important to follow certain very simple rules. It is remember that if you have a CTG like this, where there are a lot of accelerations and a lot of variability going on, try to find a part of the CTG where it is most horizontal and least oscillatory. And it should be a period of at least 10 minutes. And then you have to take a mean of it. And then you know that that is the baseline fetal heart rate. So it is important that this baseline is interpreted over a period of 5 to 10 minutes. And it is calculated as a mean level. Normal baseline fetal heart rate is between 110 to 160 beats per minute. A lot of times we talk 120 to 160, but remember it is 110 to 160. You also encounter many times fetal heart rate for no reason to be between 100 and 120. Remember, you have to take the entire patient as a whole. Don't just read a CTG of 105 beats per minute and start sending alarms that this is abnormal. It can be because of a lot of reasons like post-dated pregnancies, sometimes a woman experiencing maternal hypothermia, sometimes if she's on beta blockers, and fetal arrhythmias are also possible causes. But remember that when the heart rate, fetal heart rate goes above 160, it is called as fetal tachycardia. And you have moderate tachycardia, which is 160 to 180, and more than 180 is definitely abnormal. Now, the commonest cause of fetal tachycardia is hypoxia. We know that choriomnitis also presents as fetal tachycardia. Hyperthyroidism, especially because the maternal heart rate is increased. Fetal or maternal anemia or fetal tachyarrhythmias. Similarly, fetal heart rate less than 110 is bradycardia. If it is 100 to 109, it is moderate. And if it is less than 100, it is definitely abnormal. And why does it happen? Because of prolonged cord compression, because of cord prolapses, because sometimes epidural and spinal anesthesia can also lead to bradycardia. So that basically happens because of hypovolemia and hypotension. So it is a good idea to put the patient in the left lateral position and then reassess the fetal heart rate. And maternal seizures can also lead to bradycardia. That is why a lot of times what happens in the labor room, that if a woman who has come with eclampsia, when she comes, we immediately resuscitate her and we give her magnesium sulfate. The commonest mistake which we make is immediately we apply the cardio probe onto the maternal abdomen, and then we start panicking that the fetal heart rate is going down. Now we have to wait. When the mother gets stabilized, only then we should do the CTG. Otherwise, invariably, you will find fetal bradycardia soon after a maternal seizure. Now, the next most important thing is variability. Now, our eyes are trained to see if the the baseline fetal heart rate is coming as a straight line or there is a zigzag pattern to it. But if anybody asks you, you should be able to count the variability by counting the boxes and seeing what is the variability between, what is the difference between the peak and the trough, and that gives you the variability. This also has to be done in a 1-minute segment and expressed as beats per minute. Normally, it is between 5 to 25 beats per minute. When the variability is less than 5, for at least a period of 50 minutes again. So, for you to say that a CTG is becoming abnormal, you should have a reduced variability, but that should be for a minimum period of 50 minutes. Or if a woman is having a deceleration, then during deceleration, if she is having loss of variability, that is an ominous. Now, why does this happen? Again, it's a sign of fetal hypoxia. So there is a high degree of subjectivity in this parameter. So it is very important that you reevaluate the CTG if you have any doubt that whether she has a variability which is significantly abnormal or not. Now, the causes of reduced variability are sleeping fetus. Now, we know that a fetus has a sleep-wake cycle, and usually a fetus is sleeping for at least 40 minutes. So, if you think that you're getting a CTG where the variability is poor, either wait for some time and then stimulate the baby and then repeat the CTG, or you ask the mother to take a stroll, come back, and then repeat the CTG. Most of the times it will be normal later on. Sometimes fetal acidosis, especially if reduced variability is associated with deceleration, definitely abnormal. Now, again, a lot of times we give magnesium sulfate. Benzodiazepines are, of course, not used. Methyl dopa is also not used. Opiates are also usually not used anymore. But magnesium sulfate, remember, again, eclampsias, we give magnesium sulfate, and soon after that, we take out a CTG. We either find bradycardia or we find reduced variability. So we have to be careful about that. Just wait for some time. Of course, remember that reduced variability is going to happen with magnesium sulfate. So evaluate the patient as a whole and then take a decision. Similarly, if the fetus is premature, less than 32 weeks, this fetus is bound to have reduced variability. Now, acceleration, we are all very fond, and it is something which we all really like, really like accelerations. We know it is when the baseline fetal heart rate rises by 15 beats per minute and lasts for at least 15 seconds, then we are happy to say that this is an acceleration. If you get an acceleration, it is good. If you don't get one, please don't be disappointed, because it is not, absence is not really of any known significance. Now, most of them, they coincide with the fetal movements. And of course, it says that the autonomic nervous system is intact. If, however, if a woman has a lot of risk factors, medical disorders, then taking a cutoff, and if you have to do fetal surveillance before 32 weeks, then of course the cutoffs are taken as 10 seconds and 10 beats, not 15 seconds and 15 beats. And after 32 to 34 weeks, because that is when the fetal behavioral pattern it sets up. Then usually accelerations do not occur when a fetus is sleeping, which is approximately a 40 to 50 minute cycle. So then you need to repeat it and see if you really want to. Otherwise, loss of acceleration does not really mean anything. Now, next we come to deceleration. Yes, deceleration is something we have to be very careful about. Like how you have acceleration, 15 beats and 15 seconds. Similarly, deceleration is also decrease in the fetal heart rate, 15 beats below the baseline for minimum 15 seconds. Now, types are usually, there are 3 types: early, variable, and late. We used to use this terminology, typical and atypical, but now this terminology is not used anymore, because now we only classify it as early, variable, and late. I will tell you all the details in a short while. Now, why do we say, of course, you all know, I just want to, just revise it, that we know that when the contraction is happening and the deceleration is timed with the contraction, the nadir of the deceleration is at the peak of the uterine contraction. So you know that this is an early deceleration. However, if the deceleration starts happening once the contraction is ceased, then it becomes a late deceleration. And when deceleration does not have any relation to the uterine contraction, then it becomes a variable deceleration. So as you can see in this picture, as the uterine contraction is happening, the fetal heart rate is dipping down. Almost every contraction, you can see that the fetal heart rate is dipping down. So these are early decelerations. Early decelerations, again, not something to be too much worried about. They usually happen because of head compression, because the head is being pressed down and there's an increased intracranial pressure. They're completely normal in first stage and late first stage and second stage. But obviously, you interpret these decelerations as early only when you attach a tocoprobe also, and you're able to get a graph where the nadir of the fetal heart rate is coinciding with the peak of the uterine contraction. Now, variable deceleration, as I just said, that they don't have any relation. They usually happen because of cord compression. Now, cord compression can happen due to various reasons. Sometimes when the glycer is a little reduced, the cord gets compressed very easily. So again, we have to see a lot of things whenever we are evaluating a case of variable deceleration. We know that they're variable in duration and they don't have any relationship. They're seen in labor, especially with oligoamnios. Why it's happening is because the umbilical vein is occluded first, and this causes a decrease in the venous return and cardiac output, and which leads to an accelerated response. As you can see here, that these decelerations don't have much relation to the uterine contraction. Now, if you have certain components of variable deceleration, then remember these variable decelerations are ominous. And what are they? So what is actually happening is each time the deceleration is happening, it is leading to shouldering. And when we say shouldering, we mean that the fetal heart rate comes to the baseline and then shoots up. This is shouldering. So shouldering should happen normally. But if with variable deceleration, the shouldering is not happening. You see, here it is going up, going up, going up. It should go up further. But however, if it is not going up, you know that you're losing the shoulder, and that is ominous. If suppose, like how we saw here, these fetal heart rates are returning very quickly to baseline. Now, this is normal. However, if the return to baseline is slow, sorry, then of course, this is an ominous feature again. Now, sometimes what happens is that the fetal heart rate will go down from the baseline deceleration, and then it does not really come to the baseline and it continues there. That is also ominous. Second thing is that suppose when the deceleration is happening, the variability is lost. So these are 4 ominous features of variable decelerations. So remember, nowadays, decelerations or variable decelerations are not called as typical or atypical. However, there are just these 4 features which are of concern during the variable decelerations, and we should remember them. Next, we come to late decelerations. Now, late decelerations characteristically, when the uterine contraction has finished, the fetal heart rate is touching its nadir. So that means the fetal heart rate starts dropping when the contraction is waning off. And when the contraction is not there, that is when the fetal heart rate is at its lowest. So this happens because of fetal hypoxia and reduced blood flow. And this is something to be worried about. Other conditions are maternal hypotension. Sometimes women will be having hypostimulation because of our induction agents, if we are not careful enough. And of course, in FGRs. As we can see here, these are you see here, these are the uterine contractions. And this is a deceleration. Similarly, here we can see that these are all late decelerations. Here we are able to see that there is variability, but you can see how slowly they are returning to baseline, and this is abnormal. Now, so these are, even if you look at the pictures, sometimes you can make out, for example, this is an early deceleration. It is like almost like a V. And this is a late deceleration. This is almost like a U, which is abnormal. So when you understand these 4 components of CTG, a way to remember and write in your case sheets is Dr. C. Brevado. And Dr. C. Brevado is just a mnemonic to remember what are the things you write when you interpret a CTG. DR stands for define the risk. Suppose you have a 30-year-old lady who is second gravida with previous cesarean and hypertension in pregnancy. Remember to write the risks as 2, previous cesarean and hypertension in pregnancy. Whether she's having contractions, yes or no. What is her baseline fetal heart rate? What is the variability? If accelerations are present or not, if decelerations are present or not, and then overall, what is your interpretation? So this is a Dr. C. Bravado, and I strongly recommend and encourage our postgraduates to use this mnemonic. This is a well-established mnemonic which is used in US and is also taught in a lot of emergency obstetrics trainings over there. This is basically to how to interpret the CTG and record in our case sheets. So this is what Dr. C. Bravado is, that you have to write all these things. And then overall, you write your impression, whether this is normal, whether this is suspicious, and what you're going to do about it. Now, next thing we come to as the guidelines. So now there are 3 prominent guidelines which talk about interpretation of CTG. NICE came with a 2017 guideline, and now we have an amended 22 guideline, which is very similar except for a few changes. FIGO guideline still stands at 2015 and ACOG guidelines 2010. So all the postgraduates must go through these guidelines to get a clear understanding of CTG. Now the NICE guidelines, they basically categorize the CTG into 3, which is reassuring or white, non-reassuring or amber, and abnormal or red. So it's almost like a signal, the traffic signal, only the colors here are white, yellow, and red. So white is good, yellow is in between, and red is bad. So this is again what we have just talked. So you don't need to really memorize all of them because they're all the same. Remember the white and remember the red. The rest, everything is in between yellow. So this becomes easy to remember. Variable decelerations in which up to 50%, when they're present in up to 50% contractions, they are amber. And variable decelerations in more than 50% of contractions become red. Now, depending upon whether you have a white, you have an amber, or you have a red, you decide what has to be done. Now, suppose if all the features are white, then obviously everything is fine. Just continue her fetal surveillance like usual and continue with the management. Now, you say the category as suspicious if you have 1 amber and 2 white features. Now, in this case, maybe there is something going wrong with the patient, which you can easily correct. For example, maybe she's having a uterine hypertonus. Maybe she's lying supine and she's having a hypotension. Maybe there is some kind of a cord compression happening because of position. So it's a good idea to do an intrauterine resuscitation. Like what we do is put the patient in left lateral and give her oxygen, or, maybe just let her be in the left lateral position and then redo the CTG. And of course, pathological CTG, you say whenever there is at least 1 red feature or 2 amber features. Now, this is something which you have to be really quick about to understand. Exclude whether there is any cord prolapse happening, abruption, or uterine rupture. And if there is any possible cause which you think is leading to it, you can easily correct it, which is called as intrauterine resuscitation, but also prepare at the same time for urgent delivery. Certain conditions like acute bradycardia, or when there is a prolonged deceleration for 3 minutes or more, then again you have to expedite the birth. Now, also remember that this is a very easy table to remember. It's again the same which we have just talked, and it is again given by the NICE guideline 22, and very, very easy and very, very clear to understand. Baseline rate we have just memorized. The variability, remember, if it is more than 5, it is normal. And however, if it is less than 5 beats lasting for 40 minutes, then of course it becomes suspicious. However, if it is less than 5 and lasting for more than 90 minutes, because here you're going to take into account the fetal sleep cycle, but if it is there for more than 90 minutes, it becomes abnormal. Decelerations, early or variable, then you say that they can be suspicious. Again, here they've written atypical, but we don't use this term at all. And prolonged deceleration for more than 3 minutes is abnormal. Okay, accelerations, if they're present, they're good. If they're absent, it doesn't matter. So this is again the same thing, that remember that you have to, in normal, that means everything is fine. Suspicious, identify the cause and move on. and pathological, see if there is a cause which can be corrected, otherwise plan for urgent delivery. ACOG guideline categorizes CTG. What I was just talking right now was NICE, 2017 amended to 2022. ACOG still says category 1, category 2, and category 3. Now it's easy to remember this also. Category 1 is same as the normal one. Category 3 is same as the pathological one. And category 2 is like a dumping category, where anything which does not fit into category 1 or category 3 becomes category 2. And so the rest of the things are similar. Now here it is again the same, that if it is category 1, just continue. Category 2, continue the surveillance and do the intrauterine measures. And category 3, resuscitate the fetus and prepare for delivery. Similar tables in all the 3 guidelines. I've put them up here so that you know that they are not much different from each other. Now I come to the pitfalls in cardiotocography, because a lot of times we make mistakes when we're interpreting. So remember that a fetus can be sleeping. Please don't be in a hurry to do the CTG, and don't be very quick to interpret it, because that's what we do in our busy labor rooms. Maybe just take a CTG for 10 minutes and then we start texting each other and trying to understand what has to be done. Fetal heart rate should be monitored for at least 40 minutes if there's something going wrong. And you should also try and stimulate the baby. Diagnostic value of NST before 32 weeks varies. But of course, if you have to do in a high-risk mother, then 10 beats in 10 seconds is the criteria. Interpretation should be done very carefully, because otherwise it leads to a very large increase in the cesarean rates. A lot of drugs which we give sometimes have a lot of effect on the CTG. So remember that also. Falsely reactive NSTs also happen in asymmetric FGRs, oligoamnios, because of cord compressions. So try and, do an intrauterine resuscitation before you jump to expediting the delivery. So sometimes when you are applying a TOCO, if you have applied very, tightly, then again it leads to wrong uterine contraction monitoring. Sometimes when the woman is very obese, then it can be difficult to get the TOCO probe on. Sometimes what happens is the fetal heart rate probe also picks up the maternal heart rate. In twins also, it's very challenging. And with the medical legal things and everything, it is important that we keep the CTG records for storage. Now, the CTG papers, they usually have a thermal print on it. So if there is anything potential litigant, we should take a photocopy of it and attach it in the file, so that even if, because the thermal print goes away, but however, the Xerox copy will always stay. Now, before we end, there are 2 complex presentations of CTG which I would like to tell. One is saltatory pattern and sinusoidal pattern. Saltatory pattern is a pattern where you have a very high variability, more than 25, and it's lasting for at least 30 minutes. Now, this is also happening whenever there is a rapidly developing hypoxia, uterine hypertonus, and the repeated hypoxic insult is happening, especially in second stage. As you can see the CTG here, there is completely no baseline. The fetal heart rate is going up, down, up, down, up, down, and you can't even make out what is happening. So this is again indicative of acute fetal hypoxia. Similarly, sinusoidal pattern is a stable baseline. However, there is no variability. And this happens because of, we know, an RH disease where the fetus is immunized, where the mother is isoimmunized and the fetus has anemia, sometimes abruption. And so this is how the sinusoidal pattern looks like, which is like a zigzag pattern. Remember, there is loss of variability here. So this is what the sinusoidal pattern is. There is something called a pseudo-sinusoidal pattern also, which looks like a sinusoidal pattern, but it is actually not. Its duration is less than 30 minutes. And if you see carefully, actually, there is variability here. So this is wrongly interpreted as sinusoidal. It is pseudo-sinusoidal pattern. Now, just last 2 minutes of advanced methods for postgraduates, because they should know when they're taking up the exam, what are the new methods which are coming. We know it is continuous CTG. But remember, continuous CTG does not give you any positive results in low-risk women. It only increases the cesarean delivery rate. So you should know which women to apply continuous CTG and where you should not. The good thing about computerized CTG is that, one is continuous CTG. Now we have computerized CTG. So computerized CTG is that you don't have to do any interpretation yourself. With the AI and everything coming on, I'm sure that we will also have machines which will tell you that it is wrong, it is red, or it is amber, or if it is white. And this is a method of doing it. There is a short-term variation of fetal heart rate which the machine can calculate, which you can't see by your naked eye. And if the STV is low, which is less than 3 milliseconds, then you know that the fetus is hypoxic. So there are studies which have been done using this computerized CTG, and they have found that there is a significant reduction of HIE. Next is fetal ECG. Maybe there'll be a time when we will be actually putting in a probe on the fetal scalp and also recording the fetal ECG. The concept behind it is that the myocardium of the fetal heart is always protected till the very last. So if there is a fetal ECG change, so that means fetus is definitely hypoxic. This last thing is about STAN, where you measure the ST segment, ST and T wave in the fetal ECG, and that is how you determine whether the fetus is hypoxic or not. So it basically takes into account the ST segment, T wave, and TQRS ratio. I'm very sure in the next few more years to come, with AI and everything coming into medicine, we will soon have all these things telling us what is normal and what is abnormal. So all these are STAN, again used by the computer. So to conclude, remember that interpretation of CTG is extremely important, and keep it as normal, suspicious, or pathological. Try taking simple measures like you want to change the fetal maternal position to left lateral, hydrate her if you think that the perfusion is a problem. Stop oxytocin infusion, maybe she's having hyperstimulation. Give her acute tocolysis if you think that it's because of uterine hypertonus. Consider immediate delivery if there is prolonged deceleration or cord prolapse, placental abruption, etc. So also give antipyretics. These are also an important intervention, because if she's hypothermic, she's bound to have fetal tachycardia. So instrumental delivery can also be done if the cervix is fully dilated, and of course cesarean section if you think that the patient cannot deliver vaginally. Thank you so much.
It was really wonderful, this thing. Very nice talk.
Thank you, ma'am.
Chairpersons, please.
Chairpersons. Thank you, Smriti ma'am. Can I talk, ma'am? Am I audible?
Sure,
Yes.
sure.
Actually, I'm on the road, so there must be some disturbance around, but I'm very sorry for that. Thank you, Smriti ma'am. It was really a very elaborate talk on CTG. And I would like to tell the postgraduates that CTG is a very easy, simple, yet important tool in this era of Dopplers, but still CTG has a big role to play. And the most important thing is that Dopplers are more subjective. And I think CTG is an objective way of evaluating the fetus. More important than this is to have a proper interpretation of CTG. So if you interpret CTG properly, it will give a lot of whole insight into the fetal well-being. So really thank you, Smriti ma'am. You've covered the topic right from A to Z, all the points, and even the newer pneumonians like Dr. Brevard and all. I think they should know and interpret. So if they will have a common way of interpreting all the CTGs, so that will help in the diagnosis, and also you'll have a uniform management of doing it. So really thank you, ma'am.
Thank you. With the AI coming in, I'm very sure that this talk is going to become redundant in the coming years.
No, ma'am. Finally, AI is also run by humans. So unless we put in properly, it won't give proper results.
Yes.
Yeah, really amazing talk by everyone. All chairpersons are really wonderful. Very nice here. Sir, please.
Thank you, ma'am. Thank you, Smriti ma'am. Thank you, Saili ma'am. Thank you, Ajit sir. Thank you for this wonderful session. I would like to thank Dr. Shushma Deshmukh, our president of NOGS. I would like to thank the case presenter, Dr. Vaishnavi Nikam, Dr. Padmana Samant ma'am, and Dr. Kanchan Vidbute ma'am, our examiners for preterm labor.
Tina.
Welcome,
Hello.
ma'am.
Yes, I, Dr. Pragati is here.
Hello, ma'am. I would like to hand over to
Great,
Dr. Pragati ma'am.
Smriti giving such a nice lecture. It was really excellent. So, really, I think I should do my duty. Though I joined late, I just rushed from the OT. So, first of all, I really apologize because I was late to come to the session. And in this era of Tirgur Sankrant everywhere, and Lori and all. I wish you all a very happy and colorful year coming ahead. I am thankful that today with PDMC, Nagpur OBGY can do its 18th PG Star series on preterm birth, and it would have been excellent session. I'm thankful to today's examiner, Dr. Padmaja Samal and Dr. Kanchan Vidmute. Thank you so much. Presenter Dr. Vaishnavi Nikam, thank you for presenting interesting case at this PG Star series. Today's speaker, Dr. Smriti Agrawal, has done wonderful job and she has detailed each and everything about CTG. Thank you so much. Today's chairperson, Dr. Deshpande and Dr. Saili Jagirdar, thank you for chairing the session and being with us. And Dr. Tina Pramanik, as her name, you have been a good MOC. You have been handling the case in my, so well. And last but not the least, our Dr. Prachi Dixit, Dr. Bhakti Gujar, and Dr. Anuja Balarao. They have taken such a wonderful task on them, and this is a beautiful program of spreading knowledge, spreading light all over the, all over India, all over the globe. So we are thankful to them for conducting this program so, flawlessly throughout the year. Thank you so much. Last but not the least, all the delegates who have logged in. Thank you so much, and our partners, Corona. Thank you all.
And Vaishnavi, you also presented very well.
Okay.
Yeah.
I just missed her case and would have said.
Thank you, ma'am.
Yes. Thank you so much.
Thank you so much, ma'am.
It was a great
opportunity.
CME.
It was a very great opportunity to present in front of all the seniors.
But this is a good learning
I wish to improve on some parts.
Also attend, it's such a good experience, and even for all of us, we have learned so much through this.
Yeah, really, we are also learning.
We are learning so much,
Dr. Smriti really given a wonderful talk. Really, so many new things to learn.
That measured series, not only PGs, practitioners are also learning out of.
Yes.
No, and I really salute your enthusiasm, Dr. Sushma, that आप इतने अच्छे से सब चीजें करते रहते हो. I don't know from where you get this zeal and energy.
I try well because you friends are there to support me.
Wonderful, always. Thank you so much. Can I leave now?
Yeah.
Thank you.
Chalo, bye-bye.
Bye. Happy Makar Sankranti to all of you.
Happy
Happy Makar Sankranti, ma'am.
Oh, thank you.
सायली कुठे चालली म्हटलं?
कुठेच नाही मॅडम. IMA फंक्शन चालू आहे अमरावतीला, सोडायला आले होते मुलीला.
अच्छा. Okay.
Starting from tomorrow, next 3 days are all dances, skits and all.
Achha. Amravati is very vibrant society, always taking prize at AICOG, and all your team in the inauguration program, installation program where they are waiting for their prizes.
No, IMA function, ma'am. Amravati IMA functions are going on. But that is also a big event.
Yes.
Thank you, ma'am. Thank you for giving opportunity to be here.
It's our pleasure. Vaishnavi, show your face at least. I couldn't hear you speaking.
Yes, ma'am.
Ma'am, actually, the video of this laptop is not working.
Yes, it is not getting
Vaishnavi, put on your video, dear.
Yes, ma'am, but the video is not getting connected. We're trying from long, ma'am.
Acha.
That is why you would have left to be on screen, ma'am.
Chalo, send your picture in the group again, please.
Yes, ma'am. That will work. Thank you. Have a good day, ma'am. Bye.
Yes.